Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Dr. Theresa McDonnell, Senior VP and Chief Nurse Executive at Duke University Health System. Dr. McDonnell, welcome to the show.
Thank you so much, Matt. It's a pleasure to be here.
So what I always like to do before getting into the main part of the conversation is to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So Dr. McDonnell, the floor is yours.
So I wear a few different hats here at Duke. First and foremost, I have to call out that I am an acute care nurse practitioner. GI oncology is my clinical subspecialty, and I have the honor of still seeing patients because at the end of the day, that's the why underneath of everything we're doing in healthcare. Add to that, I get to serve as the Chief Nurse Executive and Senior Vice President for the system, meaning that I support somewhere on the order of about 9,000 nurses and patient care services staff. And I also proudly wear a hat for the School of Nursing, where I am the Vice Dean for Clinical Affairs. So really kind of bringing everything together, the academic piece, the clinical piece, and the clinical care piece.
Yeah, that is a few different hats to wear, although it sounds like they all intersect pretty well. And I think before kind of parsing apart what all of that ends up entailing, I always am curious to know as well, what got you into healthcare in the first place?
Well, that's a really good question. Healthcare is actually a second career for me. I was at a juncture in my professional life where I was either going to pursue a master's in education and continue down the path of teaching. I actually ran a Montessori school, or I was going to take the leap and go into nursing. And what led me down that path was a series of life events, some pretty significant family illnesses. No mother ever wants to get the news that their child is the sickest at a large academic medical center on any given day. And I'm happy to report that that child is alive and well and living a great life in Boston. But, when you're there advocating for a sick family member or loved one day in, day out, and you realize all the things that can go right, as well as all the things that can go wrong on any given day, and how they can impact people's lives, it really makes you think. And I had started thinking about and having conversations about maybe pursuing nursing because, when you are that family member, you become an advocate and you educate yourself on everything around that person's condition. And my husband and I started getting the questions. What's up with you two? Are you in the field? Are you, doctors, nurses? What's the deal? And we were like, no, we're engaged, really committed parents who want to understand what's happening with our son. And, a year later, landed at the same hospital, Mass General Hospital. And my father was dying of interstitial pneumonitis. And after his death, he was there for about 30 days. After his death, I looked at my husband and I said, you know what? I only need to be hit in the head so many times until I realize that what I'm meant to do is to go into nursing. So I started taking prerequisites. He died in November. I started taking prerequisites in January. And by September, I was fully matriculated in the direct entry program at Mass General Hospital. And I never looked back.
That is quite an amazing background. It seems like you're talking a lot about that ability to really connect with families and patients. So I guess from your perspective, is that kind of what is at the heart of nursing, and what is nursing's role currently? Because I feel like it's nurses are in the news a lot, but whenever something's in the news a lot, that also means there's going to be a lot of glossing over the actual fine details.
That's a complicated question. At the end of the day, if you drill down, nursing is a component of a multifunctional team that comes together around the care of patients and families. And we are the ones who are managing the patient's response to treatment, to the condition, to all of the influences that are bringing patients to a juncture where they either need guidance and counseling on health and wellness, or they need advice, care, and counseling and education through treatment and a condition. And I think we're at a very interesting juncture in healthcare, because for the last 5 years, we've seen this kind of metamorphosis where at the beginning of the pandemic, nurses were heroes and we were out there fighting and battling, and there were all of the incredible images of nurses. And then it turned to, a narrative of victimization, right? We were burnt out. We were battling with a lot, and there was anxiety and all of that. And actually, that was the first time in several years where nursing actually slipped out of being number one as the most trusted profession. And as we came out of that, there was this, the great resignation and the narrative of burnout. And now here we are. And never before have we faced so many changes coming at healthcare at once. And I think now nursing has the opportunity and must take the opportunity to lead. How are we going to innovate? How are we going to change models of care? How are we going to integrate technology, AI, and really transform healthcare delivery to one that is more cost effective and really suits the needs of what our patients need in 2025 and beyond?
So to be able to seize a lot of those opportunities to lead, from your perspective, what actions would be helpful in being able to take that bull by the horns and become the leaders that you're envisioning?
We need to have a voice. We need to speak up. It's so interesting. We're in healthcare. We talk about continuous improvement, process improvement, quality management, quality care. And nurses are there on the front line. And there's a whole methodology of management and care delivery systems that supports, if you see a way to improve something, even if it's small, speak up, try it, do it, learn from it. And for whatever reason, we've gone through a generation of nurses that they're so fixated on delivering on the evidence that they've almost lost the ability to have a voice and say, well, what if we try it this way? What if we do it that way? What if we think differently? It's really on us to speak up, try innovating. And I think we're also, at a time where there is a very strong narrative in the media that, there's fear that AI is going to take the job of the nurse. It's not going to happen. It can't, because until we've got someone to replace the human hands at the bedside or, in the clinic or on the other end of the phone, yes. Can we use AI to help support nursing work? You bet. But it won't replace us. So we should actually be the ones leading and figuring out how to integrate all those things.
Yeah, no, I fully agree with that, because it's, any discourse, as you're saying, that is trying to posit AI or really any technology tool as a complete replacement is just very off base in terms of the current reality. But before, I think, exploring that further, you're talking about, encouraging people to speak up and use their voice. So does that go into needing to kind of change the educational background of folks to get them comfortable with understanding kind of what their role is and the power that they can bring from their perspective?
Yes. And one of the things that we're keenly focused on here in I will call it the Duke Health umbrella because it includes the school, is making sure that our nurses, when they're getting their RN, so when they're in that first phase of training, that we are integrating things like problem solving. We're integrating things like finance, so that they're getting that education as part of their basic nursing training, process improvement. These aren't things that have typically been part of the nursing curricula, but many of us firmly believe that these are tools that nurses need to have when they're graduating and going into practice. Because you look at things differently when you have that broad-based understanding and background. We've seen it with our medicine colleagues. We have seen that medical schools are starting to integrate more of that. Nursing has lagged a little bit behind, and now we need to really shore up ensuring that people understand the entirety of what it means to be part of a care continuum.
So when you're thinking about kind of expanding that understanding of the care continuum, is that integrating into classroom education, clinical education, or both?
It's both. So we can give people the basics in the classroom, but then we need to translate it into the clinic. And the other thing that we're seeing is that, we need to make sure I'm gonna loop back just a teeny bit now on this concept of burnout. We see the majority of the turnover in the nursing workforce occur in the first 3 years of practice. And it's around issues of feeling valued, feeling burnt out. Well, the reason people get to that place is because they're not feeling confident and competent in their transition to practice. So what we're doing, again, here at Duke Health, because we're fortunate we can do this, is we're getting our nurses into the clinical environment sooner where they're likely going to be practicing. So we get the opportunity to really start working with nursing students in their first semester, starting to tease out what their interests are as they're going through their standard clinical rotations. This all culminates to when they get to that last semester and they do the capstone or a focused, intense clinical rotation, and it's usually in one area with one preceptor. Leading up to that, we've got an understanding of what their interest is. So if it's med-surg critical care, we're going to get them those final 240 hours working in a unit where likely they can be employed when they're done. So we get to get them intensely comfortable in that environment, understanding. So when they come off orientation, likely they've got a shorter orientation, but they feel a heck of a lot better than a new grad that I'm hiring off the street who doesn't know Duke, who doesn't know our systems, who may not have had the intense clinical exposure and training with that other background so that they can understand the systems and the finance and the issues behind some of the decisions that we make that drive what the clinical environment looks like. And it could be in an ambulatory setting. It could be in a virtual care setting. We're looking at putting our nurse trainees in all of those areas.
Yeah, no, and that intuitively makes sense because it's, I think implicit in what you're saying is that final training is essentially a preview of what their job is going to be because they're getting to focus on their expressed area of interest, as you said. And for those of you just joining, I'm talking with Dr. Theresa McDonnell from Duke University Health System, kind of talking about the current state of the nursing profession and education, and kind of picking up on that integration that we were just talking about. Do you see one that are people changing their mind with any degree of frequency as they're doing that, or is it really helping them to, as you said, get that deeper connection with that preferred area that maybe that was their initial inclination, and now it's being proven out that it is the area that they do want to practice in?
Well, when they start in the new role, if they've had this intense exposure, we find that, yeah, they're good for probably 6 months to a year. But we also know we have a generation that isn't going to be working in the same job they start in 10, 20 years ago. 10, 20 years from now, sorry. And, so the other piece of this is we're also working with our staff on how they're feeling. Are they still interested? Are they engaged? Do they want to try? And we're having mentoring conversations around what they want. What are they thinking? Is this somebody who wants to go on and be a CRNA? Well, if they do, then we've got all the tools then to help get them connected with a mentor at the school, help get them clinical exposure in the ORs in that environment, and we can then guide them through to admission to the program where they can do their training again here at Duke, and they can train with us, work with us, and at the other end of that, we've got a committed employee who might stay for a few more years. And then maybe they want to go into a research track or an administration track. What we really want to do is we want to give people the opportunity to really have that support through the career continuum. And they can change it up. They can get exposed to different things. They don't need to leave our system to do it. We can support them through that change and transition.
Yeah, no, and that makes sense as well because I think as you rightly said, people are shifting around so much nowadays that it's you kind of have to have that built-in support to enable the shifting around. And I think that probably then feeds into one of the other areas that you already mentioned, which is the role of technology, where I'm probably still at the right point where I remember things before it was really the technology really started exploding, but I grew up with it to some degree. But I think generations behind us, that's all they've known. So how is that? How are those expectations not only shifting education, but then hopefully positioning folks to as you were alluding to earlier, playing an active role in the development and deployment and integration of the tools.
Yeah, and all of the opportunities are coming at us fast and furious. So I'll touch on a couple things. The thing that's gotten, I think, a tremendous amount of attention is the ambient listening technology. And, there's tremendous hope we talk about physician pajama time because people are writing their notes and doing their documentation after their workday. And we've now got technology. There are a number of different vendors that, from your iPhone can pick up a conversation and load the note. Well, we're now seeing Microsoft has Nuance. There's a couple of other companies that are starting to develop pilots around nurse documentation. And where we're piloting some of this, we're seeing mixed uptick and mixed success. And what we're learning is we need to make sure that people understand effective communication going into the work. Because we have an entire generation that has been so used to a world of text, not being on the phone, less, in person, a lot of Zoom, a lot of other things, we've lost some of the elements of the art of a conversation that makes it sometimes difficult for those ambient technologies to pick up the pieces of information they need to pick up to then load into a templated flow sheet. So we're now doubling down on making sure that we're educating people around effective communication. The other piece to this is we've had AI in healthcare for a while. Triage algorithms, even something as simple as, robocalls to remind patients of an appointment. We've had some degree of technology. But where we're going fast and deep is around patient monitoring, smart rooms, smart clinics. How do we engage AI and technology in helping ensure patient safety? We can build rooms that can actually monitor patients in a HIPAA compliant and safe way, but that look for cues for when a patient's getting out of bed. That gives time back to nursing to then help educate patients and make sure that we're delivering on those special components of the role of the nurse that we can't use technology for. Sitting a sitter in a room isn't as effective as hopefully having a really enhanced AI algorithm in a smart room that can give a cue to the nurse that something's happening and to go and respond to the patient. Because what we've all seen over the course of our careers, that having sitters in the room, they're not highly skilled, highly technical staff that, and patients also can react quicker than a sitter who may only half be paying attention can respond to. That's just one example. End of shift notes, other things that can help make us more effective. We need to leverage these technologies to then get us back to the work that's really value add.
Yeah, and that definitely goes back to the point you made earlier when you first brought up the technology, which is it's not a replacement, it's an extension of capabilities or an enhancer of capabilities where, when the technology is deployed effectively, it is done in a way that, as you said, allows the care team, any member of the care team, to be able to increase their focus on what they should be focusing on, which is the actual delivery of care and assessment of that, as opposed to all the paperwork and all the documentation that just takes up a lot of time and diverts attention.
Absolutely. And, it helps us keep patients safe. It helps us improve the quality and safety in our environment because our product at the end of the day is keeping patients safe and delivering the best care experience we can.
Yeah. And I'd want to go back to one of the other points that you were just raising about the technology, though, especially the ambient listening technology around, it sounds like almost having to retrain people on effective communication,
Yeah.
effective interaction. So was that a surprising finding? And, when you kind of saw that happening, what was your reaction?
Well, it was funny. So we're now in our second pilot. And the first one, we were sitting around a table trying to figure out what was happening and why, it just wasn't working right. And it was myself and our chief nurse information officer, Kay Lytle, that we kind of had an aha moment. I'm like, wait a minute, Kay. They're not going into the patient and saying, "Good morning, Mrs. Smith. How are you this morning? I see that your blood pressure is 120/80 today, whereas last night it was a little bit higher. How are you feeling with that?" And it's that activity of saying the things out loud and not just writing it down on a scud sheet and going and feeding the computer. We have to talk about these things with our patients again. And, Mrs. Smith may ask, what does it mean that my blood pressure is 120/80? So it brings back actually the foundational elements of nursing that we've lost. And the aha moment kind of came with, oh, we got to teach people how to do this effectively again. We didn't think about it when we were starting our careers, but we need to teach and train because it's not about just feeding data to a computer.
Yeah, no, that's very interesting. So it's, if I'm hearing that correctly, it sounds like it's kind of like bringing education back to where it used to be when you couldn't just rely on data entry or the computer to have all that information readily available, but it's, actually presenting it and then talking, as you said, talking it through with the patient to make sure everyone understands what that information actually means.
Absolutely. And I think what we're going to find once we actually get all of this launched is I think we're going to find that we've got better outcomes because we're going to see a reduction in patient readmissions. I think we're going to see that patients' satisfaction goes up again because it's that human interaction, it's the human engagement that helps contribute to a positive patient experience. It creates a trusting environment.
Yeah, and again, that makes sense. It's, you keep coming back to that human element and that human connection. So it's Dr. McDonnell, believe it or not, we're already almost out of time. So I'm going to close with one final question, which is kind of I think a bit of an overarching one. But if you could rewrite the playbook when it comes to nurse leadership, what would you like to include in that?
Well, we are in the midst of rewriting it, and that is ensuring that our nursing leaders understand all of the components to the business of healthcare delivery and also have the elements and the confidence that they need to be effective advocates and innovators, and that they feel the confidence to lead the team. And it's leading leading with our colleagues.
Yeah, and I think that sounds like a great mission statement, and it's good to hear that, as you said, you're in the midst of that rewrite right now. So it's something to look forward to in the very near future. But as I said, believe it or not, we are already out of time. I want to thank my guest, Dr. Theresa McDonnell, for a great conversation today.
It's been a pleasure. Thank you so much, Matt.
Yeah, and thank you to everyone listening. Keep the dialogue going and connect with me at hashtag HCDEJURE. I'm Matt Fisher. Until next time.